It's time for us to start this morning's first session. The session relates to critical limb ischemia management. Dr. Dan Clair and I will be moderators, along with panelists here. Our first speaker will be Dr. Matthew Bunte, who will discuss challenges in studying a PAD and CLI program.
Thank you. Thanks for the invitation to speak. While I will address the challenges of starting a PAD program, I'm ever the optimist, and this is going to be more forward-leaning in what we need to be doing, I think, into the future here. So these are my disclosures. So I'll briefly cover, we've already had some topics on how to build a program, but really I want to focus on where we hopefully can promote the value to the care we provide in our patients and expose that and leverage that. So I think it starts with a mission and vision. Of course, as you start a program, you need an outstanding non-invasive imaging program, you need to build the referrals and markets, and establish the clinical services you're going to focus on, and then incorporate clinical research, because coming to these meetings and talking to other folks who are also at the top of their game makes you stronger. And then getting into analytics and finally quality improvements and share an implementation that we've started at our center around this. So I think the first thing to start in your mission is to be bold in your mission. And my mission when I came from the Cleveland Clinic to Kansas City was to address a number of amputations that seemed like there was an opportunity to provide more comprehensive care around and potentially limit these. And so we really started by strengthening our non-invasive imaging and setting up protocols and understanding the community need then and what our podiatrists and wound care centers needed in the community, and then built the resources we needed to take care of these folks, including our non-invasive lab, but also built a new invasive lab and the equipment, and most importantly, the human resources, the team that you need around you to have success. Then we got administrative alignment to help sustain our program, and then, of course, mentorship is really key along the way. I've certainly benefited from a number of great mentors throughout my career, but then providing mentorship, too, is equally important. And then leveraging data science, and then having focus and patience, I think, is really key, because this stuff doesn't happen overnight. So there's a number of great resources we have out there to leverage. So I think you need to define what you want to do with your program and align your program and hopefully tag on to the coattails of other national initiatives that also are headed the same direction you are, and then share your mission, both locally and regionally to your referrings. Establish excellence first in clinical non-invasive vascular imaging. That's so important in setting up a program, and then standardizing the protocols and definitions. We went through all of our vascular imaging protocols and leveraged a lot of the stuff I had learned at the Cleveland Clinic during training and implemented that in our center. But also, you know, one of the things I've learned from my wound care doctor is there really is no standard wound definition, you know, that one definition that everybody uses. So it was around the time that Wi-Fi came out, and there was a number of other classifications out there, but we've kind of standardized things around that so we talk the same language between specialties, and then develop protocols. And there's a number of great resources from national societies and initiatives that are going on that can really help support and develop your protocols at your center. And I took this from my mentor, Mehdi Shishehbor, but I added a bubble for data and analytics support, which I think is where we need to go to again, measure our outcomes and get better. Last Sunday, when I read that was a wake-up call for me in the New York Times to say, hey man, we really deserve better for ourselves, and we can offer more to our patients, but frankly, then we got to go out and get it and figure out how to get rewarded for it. So I think you can't do that without data and analytics support, but of course, all of the other bubbles in this are well known to all of us. And I think successful and sustainable limb salvage services is functional multidisciplinary care, and we have a unique center where I co-direct our vascular center with a vascular surgeon. We have 4 vascular surgeons in our program, 2 interventional cardiologists and 2 interventional radiologists, and we all see patients in our same clinic, and that's really been wonderful for all of us to get better. But trust is really hard earned, and it doesn't happen overnight. It's easily lost. It's something you have to constantly work at, but it is so worth it. Identifying key resources along the way, both internally and outside in your peer groups, finding a mentor. I've been really blessed to have Dr. Shishehbor as my mentor throughout my career. But I've had a number of other mentors in other aspects of my life, including outcomes research and that sort of thing that's really been fantastic to help me grow as a person and a clinician. And then sharing that success and growth. And so this was a road trip that my techs, we came back to the Cleveland Clinic, and I said, look, you guys got to see this amazing vascular lab that they have at the Cleveland Clinic. So as we were building our vascular lab, we took a road trip. We convinced our administrators to pay for this, and they signed the check, and we came, and it was a wonderful experience to get buy-in from my teammates too. The other thing is I think you don't have to solve the world's problems overnight. You can start small in your hospital you're at. So I work in a big health system, but I happen to be at one of our satellite campuses, and I just went to the administrators and said, look, you're having all of these wound care patients come in that are slowing down the services in our hospital, and they stay on average of 7 days. You budget for 4 days. Help me get them out quicker. They come back with 30-day readmission rates that are higher than any other acute condition you treat. Help me to keep them out by taking better care of them. So they gave us a $100,000 grant to basically hire a chronic care wound coordinator that meets the patient in the hospital, delivers all of the quality care metrics that a patient with a venous leg ulcer or a diabetic foot ulcer should get, including vascular testing and offloading, sets that patient up with all of their clinical appointments, but takes that a step further and starts to address their social needs, health-related social needs proactively in real time. And that has also allowed me to, celebrate small victories like this GE Vivid we got for our lab to provide better vascular care at the point of care, but also to develop the kind of vascular lab I needed to take care of these patients and do these cases, which has been great. But this is what I'm most excited about. Because while all that clinical stuff is wonderful, the real impact we're making is understanding how we're doing in our community. So I'm at Kansas City, and the details are not so important other than that we've mapped out the outcomes in our community. We know where our patients live. We've shown that our amputation for non-Hispanic blacks is, in fact, 4 times higher than it is for non-Hispanic whites. It's 2 times higher for Hispanics. Those are the national statistics. So then it's like, what are we going to do about it? So part of our story is we've went to our local administrators and said, this length of stay and 30-day readmission is kind of the ROI. Give us some resources. So we've now built tools to monitor and manage this population. And we have this quarterback, so to speak, this chronic wound care coordinator that is monitoring and measuring in real time, addressing both the clinical shortcomings as well as the health-related social needs. And I think this is where you start to take all this data and explain it and tell a compelling story. And so it is only through this kind of work, though, that you can address these health-related social needs. We realize that the patients that come in with CLTI have very complex, unaddressed chronic conditions layered on top of all these health-related social needs that need to be addressed. And that's the reason that we see these kind of disparities among blacks with diabetic foot ulcers versus non-blacks. It's not the melanin in their skin. It is because they come from difficult circumstances in general in these communities that we have opportunities in our community to address. We just have to connect the dots. I think part of the secret here is building trust, and we recognize the importance to that, but trying to do your best in a busy practice to meet patient needs, deliver individualized, personalized care that's compelling, that gets the patients engaged, and then provide a space and a place for your nurses and team to provide great care. And then, man, patients love this, we see it, and it feels really great. That's why we all do this stuff, but enable your patients to tell their story and get their support in this journey. I think get familiar with atypical partnerships and, reach out. Get as many folks as you can in your community. So Dr. Eric Guerra is my wound care partner in crime for this implementation program. He's a family practice doc who now does wound care full-time. He left his family practice and now partners with me and does wound care full-time. And we've set up these patient journeys through our hospital. Since we turned this on last July, we have reduced major amputations at our hospital by 50%, and we're on track to maybe even best that this coming year. We're on track right now through Q2. We're at 5 amputations, so you double that, it'd be 10 for the year. So we'll see how it shakes out, but I can tell you that this has got everybody's attention, from frontline staff to my nurses to the administrators. Everybody appreciates this, and it's worth something. It's not to say that all this isn't without adversity. It's a very difficult population to treat. It's a burden on hospitals. It's challenging procedures, competitive landscape, and there's no guarantees for success. But when you do this kind of stuff, you have a lot of fun. So when you're doing a complicated case and you step on the cine pedal to take your final angiogram, and the construction crew that's working on your hospital hits the main power line and the lights completely go out, your team goes and gets the glow sticks to finish the case. And we had to take a picture, because when do you get glow sticks in the lab? And so create space for others to be recognized. I think that's great. So I'll finish with, really find your why, find your mission, build a team, and we all need to go forth to serve. Thanks.
Thanks for a great talk. Obviously, one of the components of the PAD team is a vascular surgeon, and Dr. Clair will discuss why a surgeon is needed.
So thanks very much. I'm a little concerned about that noise. And maybe I'll get this to go forward. These are my conflicts. And what I would say is, if you don't know why you need a vascular surgeon, then in my view, you're missing the point of vascular care in general. And it's not that vascular surgeons do it all, but there are certain aspects of what we do that require a surgical approach, much like there are certain aspects of what we do that require an interventional approach. And at the end of the day, our goal is to provide the best care for patients however we can do it. And sometimes that means that you have to wind up doing a surgical approach. And it's all aspects of what we do, right? Sometimes it's aortoiliac disease, sometimes it's infrainguinal disease. It may be just dealing with the infection and the wound treatment that you need, and debridement of the foot. Obviously trauma, and when I say trauma, sometimes it's trauma that we inflict. It's not necessarily somebody outside the hospital. Could be an access problem, could be an angioplasty that's gone south. But the bottom line is, you want to be able to care for these, and sometimes they need a surgical evaluation. And I'm just going to go through two quick cases, talk with you about them. This is a young woman, and I have to admit, I came upon her late in her story, but I'm going to take you through just a couple of CTs. She had persistent right lower extremity ischemia, wound up with an amputation, and our consult was for persistent ischemia. And I went back through her CTs. This was her initial CT when she was 41. You can see that massive tumor at the top, and you also see these two parallel stents through her aorta and a lengthy stent through the right iliac lesion. You can tell from this scan that she's barely fitting in the scanner, so she's a pretty large woman. She redeveloped, after this scan, she redeveloped ischemia in her right leg, and most of this was done, again, outside of our institution. This was those same stents. They'd removed her tumor. It turned out to be a benign tumor, not a malignant tumor, which was the original concern. The stents were expanded and extended on this time into that right limb, and you can see those stents are sort of crossing in the front. Ulceration begins on her below knee amputation stump. Her wound gets infected. She has another CT scan. I'm sorry, these are running slow. That's the way the story develops, though, right? It develops over years. Now you can see she's got stents added to the top, more stents added to the bottom, stents added through the left side, and then she developed a wound on the lateral aspect of her thigh, her right thigh, a severe infection in a newly performed above knee amputation, and this is her now. And she's got 4 stents in the middle of that aorta. And this isn't actually to point fingers, because this stuff happens. We've all been in situations where you're trying to do the right thing, and you find out that you've deployed this stent outside of another stent. You didn't mean to. But the bottom line is, you're not going to correct this with repeat intervention. This person needs something done to revascularize her leg. You can tell her entire aorta is occluded. She's still obese. Now she's got a Pseudomonas infection on the outside of her leg. And trying to decide how to deal with this is pretty challenging. I mean, I'm sure there are people in here who would try to do interventional therapies, and there's no question you could probably get something to work for a little while. And even the surgical solution isn't great for this lady. And she wound up with an axillofemoral bypass graft, so we were able to do a bypass graft outside of her surgical field. She got blood flow back to her legs. She's actually healed her wound. Now, she may need to have something else done, but at least with all of her wounds healed now, she could have an open aortic procedure, she could have something else done, she could have a thoracofemoral bypass graft, a lot of other options that I wouldn't have wanted to burn as initial bridges trying to get her to this point. Second patient, 64-year-old woman, has progressive right lower extremity ischemia and develops rest pain. Now, she's been trying to walk, she's been trying to do exercise, she's been unable to do that, it's clearly getting worse. And she's taken for an angiogram. This is her inflow. She has pretty good aortoiliac flow, and this is based on a duplex. And you can see that she's got good flow into a large profunda collateral out here. So this is the origin of her SFA. And that large profunda collateral, you can see, comes down and reconstitutes a barely above knee segment of popliteal artery. And this whole segment, I don't have an unsubtracted view, but this whole thing is incredibly heavily calcified. So she has this extensive calcification. An attempt is made to do direct interventional therapy. It fails because of the reentry issues. The decision's made to convert to surgical therapy. She really doesn't have adequate vein, so she winds up with a PTFE bypass, which resolves her problem. She's several years out now with resolution of her issues. And yeah, this isn't an ideal solution, but I think the point is that there are certain times where it is very challenging to obtain a good outcome with an interventional approach, and not having a surgeon available to offer the next level of treatment is a failure on our part in terms of dealing with these patients. Thank you.
Great, thank you, Dan. As it is with any team building, I think building complex limb salvage program is a very delicate issue because it involves multidisciplinary approach, different specialties, different cultures, and all that. I'm just, I'd like to ask the panelists about how you guys build team spirit so that you rise above the turf war or specialty barriers. And if you can comment on that, and particularly with respect to the role of cath lab team, Billy, if you can comment on it and how you deal with this vascular surgeons coming in, cardiologists coming in. I would appreciate the panelists' thoughts. Thank you.
Absolutely. I mean, the landscape has very much evolved with dealing with radiology, surgery, lots of different spaces. So one thing that we try to do is always maintain a team-based approach of looking at the strengths of each part of the team. Of we're not specialists in wound care, we're not specialists in surgery, so how can each person add to taking adequate care of the patient, and always trying to explain that to the team of what we're doing, how we're saving these limbs, and try to really follow the patient's story out. And that's how I think it really adds to the team being excited about being in these cases and working together, of seeing a good outcome, or understanding when we maybe don't have a great outcome in the cath lab but need extra help. Really has helped with that, bringing together. We also have a CLI navigator that helps to bring everyone together, talk to the different specialties, and that really has collaborated our teamwork and made people excited to really work together.
Yeah, I would say at our institute, the key, I think, is communication, and to expect to have that communication between specialties. I think that we find it, we try to create an environment where, you know, we're working alongside each other, whatever the specialty is, and a very transparent type of workflow and work environment. And I think that creates the culture. And I think for this to happen, you have to create the culture, because I think you see people that come in and out, and people, you're basically leading that culture by example. People see how you interact with other people and how that service works, and they kind of fall into line. And I think that's really important, because at the end of the day, it's about that patient care and getting everyone's opinion and communicating.
I think good points. The truth is we all make each other better. There are a lot of things that we can do, all of us, but even the vascular medicine component of that's very important. There are things that we don't know, and you don't want to put a stent in it, or you don't want to cut on it. For us, we've got 6 vascular surgeons, and I'm still incredibly busy, but we get along very well. In fact, that Bo, one that Shirling trained, and we do different things. We take vascular call together. So I'll be on primary call, but I always have a vascular surgeon backup. And, I'll take all the others. But if I'm getting a ruptured aneurysm, even though I do them, I will always call and say, hey, take a look at the scan with me. I think I got this one. I got a good neck, but I want you to know. And we have M&M together, present cases. And it's amazing how when you listen to somebody from a different specialty, you learn something you didn't know you knew. And they come up with a perspective that you wouldn't have thought about if you're only one-dimensional. So I think it's important. I think, and the surgeons are very, very, as you say, Dan, in your title, it's a must. It's not the only, as there's been some pretty bad rhetoric in the last week or so, and the multidisciplinary part is the part that I think we all get better from each other.
Yeah, I agree. The multidisciplinary part is hugely important. And one thing I learned from Subhash Banerjee is, just to keep the morale up, because we're so good at M&M and just really getting bogged down in the details, because we need to know the details, right? We need to pay attention to that. But then the other thing is to celebrate the successes. Somebody who we've been following forever and their wound finally heals despite all the adverse circumstances is a success to celebrate. And we should be happy about that. I think that really helps keep the team morale going.
And I guess I'll round it out. One of the questions was about keeping the cath lab team involved and invested. And you forget sometimes that as the interventionalist, you're the only one that gets to see the person before and see the person after. And you get a sense as to why you're spending 3 hours, working on a tibial to help things heal. And so, we've worked really hard to incorporate the cath lab teams into a lot of the meetings and follow-ups, whether it's the M&M to say, here's the early recognition of things, but then also the case conferences that we do with the trainees. CVI, it does a great job kind of making access available to your cath lab technicians and nurses, as well as your team and APPs to come through. We bring them to these meetings as well, just to get that insight. Here's why we're here for 3 hours, in a leg. Here's why we're spending all this time to try and get this outcome.
I think it's hard even among surgical groups or cardiology groups, everybody suspects that, the whole cardiology team is on board. But the fact is, building a team means developing a team within your own specialty, in addition to the people outside of your specialty too. And, I've been a number of different places, and my own impression is it's education that really spans the gap. It's, showing cases what would you do in this situation, getting differing opinions. And oftentimes those sorts of things change the way that we think about a problem because we hear somebody else's view. There's a book out by a guy named Adam Grant called Think Again is the name of the book. And it's basically teaches you how to question things that you took for granted as, this is a fact, this is a known fact. And the bottom line is most of the stuff that we think we know, we really don't know. I practice very differently now than I did 20 years ago. And I do because I'm constantly questioning what it is that I thought was right for me to do before. And I'm doing things differently because I want to do them better. And I think if you're in a good group where you're educating people about how you're trying to advance things, how you're trying to do things better, there's a way to build a team in doing that through education. So our next speaker this morning is Lessons from BEST-CLI. Mehdi Shishehbor will come up and give us a talk on this.
Okay, good morning, and thank you, everyone. And what a great discussion about multidisciplinary team, because as we said, that's the only way that we can be patient-centric. So I wanted to discuss BEST-CLI. As you know, this paper was published in New England Journal of Medicine. A lot of noise, a lot of concerns. I cannot advance the slides. I'm sorry, guys. Okay. Yep, in the New England Journal of Medicine, obviously a huge kudos to the folks that participated. We were a site when I was at Cleveland Clinic, and we were a site at university hospitals, and contributed a number of patients, at least tried to enroll a number of patients. And it's huge. It's difficult to enroll these kind of patients. We discussed, Matt Bunte discussed that these patients from disadvantaged background, and a lot of these patients don't want to participate in clinical trials. So I think just completing the trial itself is huge. But when we have data, we have to carefully analyze the data. And we have to see, does it apply to my practice? And we have to be able to discuss in a very transparent way the flaws or the strengths of these studies. And I unfortunately found a lot of difficulties with this trial and how it was applicable to my practice and how we do things at university hospitals. And I just wanted to share that with you. It may be different for you. So one of the things that I was debating, you know, the PIs of this trial 6 years ago, 7 years ago when the design was formed, I was very concerned. I was very concerned because we were taking, and remember this is a trial, so we're trying to research something, we're trying to evaluate something. And when you're trying to do research, you always want to minimize noise, right? You want to minimize noise so you don't get a type 2 error. And I was surprised that in the surgical arm, we had one thing that we were studying, but in the endovascular arm was a hodgepodge without any guidance. You could do whatever you wanted, and we were comparing these two arms and trying to make a decision for the care of the patient. So that was concerning to me. And I knew that the field of endovascular was evolving rapidly, right? Yes, 20 years ago, we didn't have randomized clinical trials. We didn't have trials that had 2 years, 5 years, 8 years, 10 years follow-up. But we know now that we do. And we have to take advantage and we have to utilize that information if we're going to do a trial that's going to compare one approach to another approach. And I think the DCB is a perfect example of this. I honestly cannot see, and we have had this discussion here in this room the last 2 days, I cannot think of too many patients, maybe less than 5%, maybe somebody that has a covered stent that should not get a drug therapy at this moment in 2023 or even 5 years ago. Every patient that comes to us should get some form of drug therapy. Why? Because there are level 1 randomized clinical trials that have shown superiority of drug therapy over angioplasty. But when you go to a trial and you have this situation and you have a hodgepodge of whatever you want to do, and you're trying to then make decisions based on that trial, you get into this kind of trouble. So balloon angioplasty alone in cohort 1, and many of you remember BEST-CLI had 2 cohorts. And cohort 1, angioplasty alone, 15.4%, cohort 2, 13.8%. But more importantly to me, drug-coated balloon utilization in the BEST-CLI contemporary was 18.5% in cohort 1 and 14.9% in cohort 2. This is our utilization at my hospital. I actually think it's 100%, but sometimes if you have a covered stent, we obviously don't do DCB in a covered stent. And that's our algorithm. We do drug therapy, and then if you have a dissection or recoil, we address it. We talked about this yesterday in this meeting. So that's concerning to me. Is this applicable to my practice? I don't know. 14% versus 98%. The other issue was the experience, and this was very concerning to me from day one, because I do believe that these patients are very complicated, as Matt said. I do agree with all the panelists that you need a multidisciplinary team. And multidisciplinary doesn't mean that you have all the specialties in your hospitals. That's not multidisciplinary. Multidisciplinary is that you're seeing the patients together. There's integration. You're discussing the patients. As Dr. Clair said, you're showing cases and finding what's the best approach for this patient. Unfortunately, the level of experience, and you guys have seen the cases here the last 2 days. These are complicated cases. These are difficult cases. You had to have 12 infrainguinal 12. You have had to have done in the prior 2 years, to qualify as an operator for this study. I don't know if I'm somebody with that level of experience, I would allow them to work on my family. 12 procedures in the last 2 years to be qualified to take care of CLTI, one of the most difficult things we treat. And we know that experience is important. It's one of our papers with crowded intervention, and we showed that experience is extremely important with outcomes, and that impacts. And there are other trials that are doing it. CREST is a perfect example where they have mandated credentialing, and many of you may be part of CREST, and you know that you have to be credentialed to be an operator in CREST, because we're trying to study a technique or a device, an approach. We shouldn't negate the approach because we don't have the right operators. That's a different problem. But if you're testing an approach, we should have the best people, because the whole point of the study is testing the approach, not the operator. The other issue for me was that this biased experience really reflected, in my opinion. And this was very bothersome, because we were able to have success in 98% of the bypass in the surgical cohort in group 1. So surgical bypass was successful in 98% in cohort 1 and 100% in cohort 2. Everybody did perfect. The procedure we were trying to test, we were able to do it for those patients. But in the endovascular arm, 15 to 20% of the patients never got the therapy. This will be like if you're studying a drug and you don't give the drug to 15% to 20% of the patients in the arm that you're studying. Of course that arm is going to fail. And that to me is problematic, because this becomes more of an experience research rather than a technique or approach study. In our hospital, it's 95%. Why is it 95%? Because we have a team. We have an LSAC team. We communicate. When we fail, we fail. It's not, maybe the first time is not 95%, but if we fail doing endo, we bring it to the team. We have Dr. Cho, we have the whole team. Everybody gets on, podiatrists, vascular medicine, our nurses, our APPs. We discuss the case. We say, well, and Dr. Cho probably going to show some cases others have shown in the last couple of days where we have failed on both sides. It goes back to Dan's point. We need everybody. Nobody can do it alone. So there are cases that they're going to be successful surgically, and there are cases that are going to be successful endovascularly. But if you try to go at it alone, this is what happens. And this we cannot afford. We cannot tell patients 15, 20% in a research setting where we're being the most elite sites involved to have this much failure. That's just not acceptable. And then we go back to the multidisciplinary point of this. And this was really, I was hoping this would not happen, and I was worried that it was going to happen, honestly, 7 years ago when we were discussing this trial at various meetings. 73% of the operators were vascular surgeons, and I'm not saying this as a negative way, but it's a counter to what we're talking about. It should be multidisciplinary. And multidisciplinary, again, doesn't mean that you have the specialties in your hospital. It means that we are actually discussing. This was not mandated. And believe me, I was involved with this trial in 2 institutions. We never talked to each other. And when you do it multidisciplinary, this is what happens. You get success. And this is a paper we published from our data where we showed 95% of the patients could be revascularized, where these were patients that in our own institution, we thought they were not revascularizable. So every patient in this study were people that were being treated by vascular surgeon or interventional cardiologist, and they were felt that there's no option left. We bring them to this limb salvage advisory council, suddenly all kinds of options show up. And we are able to revascularize 95% of those patients. And of those at 6 months, we were able to save their limb 75% of the time. And then I had major issues with the endpoints, the amputation-free survival, and then the male, which was above ankle and below ankle. But most importantly, the endpoint that really bothered me was reintervention. And the reason this was important is that in cohort 1, there were 108 cases that had technical failure. Remember I told you 15% of the patients were not successful. Never got the drug, never got the therapy that you wanted to test. Those were 108 cases. If you look at the primary endpoint of this trial, there were 302 events in the surgical arm and 408 events in the endovascular arm. The difference is 106. 108 patients never got the drug, were never able to be revascularized at the time. And all of those patients went for revascularization, and obviously that was an event. And then probably the most concerning part of this, to be honest with this trial ran from 2014 and 2000 to 2019. This trial was running at 150 sites in the United States and I think abroad, Italy, Finland, and other countries. So 150 sites, and we only enrolled 1,847 patients. So a 5-6 year study, 150 sites. What happened to the other 50,000 patients? Where are the other patients? Who were they? Why were they excluded? How can we generalize a trial like this when we have such a limited cohort of the patients that were actually seen in these hospitals? This was not consecutive. We didn't include many of the patients. Over 85% of the patients were never included in this trial. So in conclusion, obviously, I'm proud of the trial. I think this was NIH sponsored. There was a lot of work that went to this. I'm proud of the PIs. They are my colleagues and my friends. I'm proud of our team for enrolling patients at 2 institutions. But at the end of the day, there are many questions that are unanswered. Who was not included in the 150 sites? What did the angiographic data show? Were these people with a 50 centimeter occlusion, or were these people with 10 centimeter occlusion? We have no idea. Why there was so much failure? Was these people that were talented, that they spent time? Did they go retrograde? Did they go antegrade? Did they try all the techniques we discussed? Or this was a 5-10 minutes dabbling, and that was okay, it failed, and that was an event. What happened to the wounds? I want to know about the wounds, because that's what we're talking about here, right? We want patients that are functional, ambulating. Going back to your point, Matt, that we want to get these patients to the end. Just because you have a leg doesn't mean that you're functional and your wound healed. And then lastly, what happened to quality of life? As you know, the quality of life was the same. As a matter of fact, it was a little bit better in the endovascular. So how do you have more amputations, but the patients are saying, I'm feeling better, I'm at better quality going under the endovascular approach? So I think there's a lot of complexities. Hopefully more data will come, we understand more. And these are my takes from BEST-CLI. Thank you so much.
So our next speaker will be my co-moderator, Dr. Cho, who will talk about, I should have sent this one for bypass.
All right, thank you, Mehdi, for the opportunity. Appreciate being here. I have no financially relevant disclosures, but I must say that I'm a surgeon, and I treated this patient and did the bypass surgery. And all the physicians who were involved with this care worked closely, very closely with me. And we are part of a great multidisciplinary team. So this is a concerted effort. A 76-year-old male presented in December of 2022 with a 1-week history of non-healing wound on the left fourth toe when he sustained a nick when he was cutting his toenails. He was seen by a podiatrist at the time, and a non-invasive study was obtained and shown here. ABI was 1.3 and had some pulsatile waveforms on the digit. And an examination showed that there was a non-healing ulcer on the medial aspect of the toe. Antibiotic therapy was initiated at the time, and the patient was followed up in January of this year by the podiatrist and was noted to have worsening of the wound. And the patient was referred to one of our interventional cardiologists, who then took the patient to the cath lab and proceeded with diagnostic angiography, which showed axial patency of femoral popliteal segment and a dominant posterior tibial artery, as you can see here on this study. But there was a isolated common plantar artery occlusion, as shown on the rightmost panel. The patient underwent a successful recanalization of the occluded segment and had a balloon angioplasty done with the completion angiography showing restoration of flow through that segment of the vessel. 2 days later, patient had a transmetatarsophalangeal joint amputation of the involved toe with primary closure. 2 days later, non-invasive diagnostic test was obtained, which showed, now at this time, the ABI is non-compressible, and there was some somewhat decreased waveform in the digits. In a clinical follow-up, the viability of the amputation site was questioned by both podiatrists and the interventional cardiologist evaluation, and this was a photograph taken at that time. The patient was then taken back to the cath lab and had an angiography which showed occlusion of the treated segment, and this was again successfully recanalized with a balloon angioplasty as shown in this angiogram here. In a follow-up visit, non-invasive study was once again obtained, and here is non-compressible 1.4, whatever it is worth, and waveform at this time was flatline. In a follow-up visit, clinical visit, the patient was noted to have worsening of the wound with a progression of the gangrene, which then prompted a third trip to the cath lab and showed again that the segment was again closed. Now at this time it's a little bit more extensive than the first time. And this was once again recanalized, and patient had an atherectomy, shock wave, lithotripsy, and a cutting balloon angioplasty with the final angiogram shown here. In a follow-up visit, the wound was not healing and required transmetatarsal amputation of the third, fourth, and the fifth digits. In a follow-up visit, this was the examination at the time, and the patient was admitted for wound care and was discharged a couple of days later, only to return 3 weeks later with this finding. So at this time, Limb Salvage Advisory Council was activated, and we had a discussion, and the decision was made to consider surgical bypass at this time. Patient was admitted and underwent vein mapping, which showed suitable conduit, and diagnostic angiography was once again obtained and now showed this. Patient was noted to have a suitable cardiac risk, and the patient underwent from below the knee popliteal inflow source to lateral plantar bypass with a single segment great saphenous vein, as shown here on this slide. That's over the graft. And that's over the native plantar artery distal to the anastomosis. A few days later, patient underwent completion transmetatarsal amputation, as shown here. And on a month graft surveillance duplex, the bypass graft was noted to be patent without any flow disturbances. And patient was seen 2 weeks ago in my clinic and was noted to have a nice healing of the wound with a healthy granulation tissue. It is expected that the patient will progress to complete healing of this wound. So what can we learn from this? In the setting of a short-term failure, after whether it is an interventional or surgical intervention, open surgical intervention, do not just repeat the same procedure. Look for the sources that led to the failure and consider other options. Because who knows, you may be fighting a bad biology that just cannot be overcome, irrespective of the methodology. Repeated interventions in the same bed may compromise the target or the outflow vessels because of the intense inflammatory changes that may be initiated by the repeated interventions, and it can cause thromboembolism and trash, which may mitigate your chance of even a bypass surgery down the road. And importantly, multidisciplinary approach is always a win-win situation for all parties involved, including the physicians and the patient alike. Thank you very much for your attention, and I'll be happy to entertain any questions.
Jay, that is an outstanding case, and I have to admit, looking at those interventional pictures, I would have not considered that there was going to be a problem. I mean, all of those images at completion looked great. But I guess the real difference is deciding when do we put down our interventional tools and pick up a scalpel. And honestly, that's an interesting question. I'd be interested to hear from the other panelists if they might have approached this differently. What would you do after the first failure? I mean, in reviewing this, Mehdi, this kind of reflects sort of what you were talking about. I mean, this was interventional failure within 30 days. So this would have been considered in that 15%. And yet if you look at this, it doesn't look bad. And it's in a position where you can't use a medicated device to treat it because there's nothing that's approved and really nothing set for that. I'd be interested to hear the other panelists' thoughts on, you know, when do you move from what you're doing to something else?
I think, Dan, that there are a couple clues here. As you said, you didn't have anything new to offer, all right? And we all know Albert Einstein's definition of insanity, but if you keep doing the same thing and it doesn't work, but on here, the things that would have said to me, you got to change course, is how quickly and badly things happen. You know, you're showing 2 to 4 weeks, and it comes back, and each time it comes back, it looks worse, and you don't have anything new to offer. So I think at that point, when it comes back, the second intervention is completely reasonable. Something happened, you kept your balloon up longer, you did something different, but when it happened twice, and it can happen in a short time frame, then I think that's the clue that we do something different. And I think the other thing that's important, just like you said, those pictures were beautiful. The angiograms, the before and after, were beautiful. It's important to give feedback to whoever operators are. All of us want to know, hey, I thought that person did great, but if there's not follow-up, that picture that looked great on the talk is not real good on the patient's foot.
Yeah, I agree. I think similar situation, seeing that angiogram, I would have done exactly the same, done endo and probably repeated it at least once because it looked so good on the completion. And I guess I just want to point out, we see very few pedal, like tarsal bypasses at this point. I mean, our trainees don't get trained in them, but it's such a good operation in the appropriate candidates. Like, I think a lot of people would see this, and when the endo failed, they would have probably just left it and not considered a bypass. But, you know, the tarsal bypass is still a really good option in the appropriate patient.
You know, Mehdi did a great job talking about BEST-CLI and some of the limitations. One of the greatest strengths I think we've seen in the community is people being more willing to take on some of these complex bypasses, which really were the cases that got randomized. You know, as was described, not to keep talking about BEST-CLI, but it was great that that trial was done. You know, we have 23 randomized control trials between CABG and PCI of 13,000 patients. We never had that question looked at in CLI. When it did, it was extremely non-consecutive, which makes it very hard to link to every patient in front of you, but it gave us good data that bypass with good conduit can have good outcomes. And I think exactly in this kind of situation with a failed, atypically fast repeat intervention, it's a great example of teamwork to get this fixed.
Yeah, and I think it's also important, the culture, right? This having the Limb Salvage Advisory Council or having a vehicle where you have that communication, right? I think it's important, and there's different ways to do it, but I think, you know, whether it's, you know, the interventionalist, when they see it, hey, that maybe we now get someone else on board, maybe it's talking to the surgeon and say, hey, it's a fem distal, fem to floor, you know, find, you know, if you don't want to do it, find one of your partners that want to do it, someone who really likes to do this, and kind of making sure that culture is there of being collaborative, finding out what the best thing for the patient is at that time. And I think you got to create that. Sometimes you have to create those avenues so people know this is what's expected.
I think this was a great case, and to reiterate what Dr. Tsai was saying, a lot of people after the second intervention, I think, would not have considered a bypass. So I love the collaboration of that. Second, very important with the follow-up, the very quick follow-up, and the importance of the interventionalist looking at the wound and not relying on somebody else. Because if this patient had come in maybe a few weeks later, it would have been a much worse outcome. So very much staying on top of these patients, following up with them, working really closely in care. This kind of what made this a successful outcome, I think.
Matt, do you think, Matt Bunte, anything from a vascular medicine standpoint that would explain, if this patient came to your clinic, Why do you think it failed so quickly so often? Anything you'd look for?
Yeah, that's a great question, Chris. I think this speaks to, we have to pay attention that the context from which these patients come. And it's often quoted that 80% of our health outcomes have got nothing to do with what we're talking about in this room. You know, it's about what you eat and where you live, and do you actually have a ride to get back to clinic? And in our institution, when we deliberately measure those things and then resource those things, and those resources are not something that individual healthcare providers can do on their own, but those resources exist in your community. Your job is to connect the dots around a diagnosis and then give the patients a chance. And once you do that stuff, I think part of the story here is, you know, where did that patient live and what were they eating? And, you know, did they have a ride to get back to the office? And those things matter too. I think making sure that as an interventional cardiologist, I'm also really keeping in mind the offloading and all the other things that lead to success for these folks. But you know, we just have had a lot of success and being intentional about measuring health-related social needs and delivering on those things and making sure if we couldn't deliver it at discharge, we're going to follow up in 2 weeks and make sure those things are shored up and continue to work to connect those dots. I think that's another important part of the story.
If I can say one thing quickly, Dan, you know, I think that this case actually taught us a big lesson at our institution, and honestly, because of this case, Dr. Cho suggested that, you know, if there is a failure within 30 days, I mean, it could be, you know, some people can say 90 days. But I really believe in it, and I appreciate that he made this suggestion, and I think we're going to take it on, is that whether you are surgical or endovascular, if you have a failure within 30 days, we should discuss as a team. And maybe the answer is to go back and do shockwave or do whatever, you know, fine. It doesn't really matter. But I think that, you know, maybe you need help. Maybe you get a few other minds, you know, on the Zoom, and that you get some more help and support in trying to help the patient. Because even though the case at the end became successful, this lady came with a single-digit, you know, ulcer and ended up with a TMA. Still, she can walk, but we could do better. And I think we need to continue to challenge ourselves and try to do better with these patients.
I mean, it's a TMA, but it's also 4 interventions and then surgery. And I have to admit that point at which you say, I'm going to stop doing interventions and I'm going to do surgery, I actually think it's really, really challenging to know what's the right thing. I mean, I have a patient I'm seeing. It's a young gentleman who had a unilateral iliac artery occlusion. And now 4 interventions later, bilateral stents, the contralateral stent is occluded and has been intervened upon 3 times. I'm going to be doing open surgery on. And I don't know that any of the things that were done were wrong. But, you know, it's clearly at some point in that 45 or 46-year-old guy, you know, now it's at the point where he's coming into me and saying, there's nothing I could do interventionally that I could talk him into because he's telling me he wants surgery. But I feel like we're not doing a good enough job if we're not reaching that point earlier, or at least having, as you say, an extended discussion about, is this the right path to continue on, or should we move over?
You know, I think what's important is that we keep patients' interests as a top priority. And, you know, Dr. Shishehbor often says we check our ego at the door and when we walk into the hospital. And I think that's very, very important. My daughter is an anesthesiologist, and until she became an anesthesiologist, my perception of the anesthesiologists were those who want to just cancel my cases. But after my daughter became an anesthesiologist, I have a completely different understanding and perspectives on anesthesiologists. And the same thing, when you have a multidisciplinary team with a good understanding of each other, and you have no ego issue, you rise above all those territorial issues and all, and with the primary interest being focused on the patient's outcome. I think that's when we can deliver the best outcome for the patients. Yes, sir. Ben?
To get vein mapping early on in the course of these patients. If you have a patient like from this case maybe before even the first intervention, you have vein mapping. If he has no good vein, you know how aggressive you're going to be from an endo standpoint, and that you might keep going, keep trying with endovascular means. If there's no vein, you're not going to do a POP to lateral plantar bypass with PTFE necessarily. So I think that getting early vein mapping can help you guide your treatment.
What I would say about this case, though, is you don't even probably need to do a popliteal to plantar bypass. You probably could have done a proximal posterior tibial to plantar bypass. So it's not just vein mapping and does he have a long segment of saphenous vein, it's does he have 15 centimeters of vein primarily that you could use, either lesser or short saphenous, great saphenous, or even arm vein in this setting. I mean, I think you're right. This is a setting where maybe even a radial artery could have been used as a conduit. So there's a lot of options for surgical bypass that we don't think about, but you're right. Again, it's that same thing, having the other approaches in your mind at the same time or as part of what your team is doing. So we should probably move on to our next talks, and our next talk will be by Dr. Benjamin Colvard, who's going to talk about a hybrid approach to multi-level CLI.
Thank you. Okay, so let's just jump right into it. This is a presentation I gave here last year, but I picked a new case for this year. This is a 74-year-old woman who presented with left foot wounds and rest pain. She had a significant cardiovascular history, CAD and valvular disease, and with recent repair, history of DVT and PE, and prior stents for claudication, as well as a smoking history and diabetes. So looking at her foot, she had a couple of ulcers distally on the foot, and then some more superficial abrasions, ulcerations beginning even at the ankle, with no perfusion detected in the foot. So this is can you run through start the videos on these? You can see this is a challenging case just because of the extent of calcification of basically every artery in her body. And when I'm looking at these cases, I'm thinking about, obviously I'm thinking about the endovascular approach. Where am I going to start where am I going to get my inflow from? What's my outflow going to be? And I'm also thinking about possible open options. Where am I going to put a clamp? In this case, you can't put a clamp anywhere in this territory that we're seeing on the CT scan. So this is a patient whose aortoiliac disease needs to be treated with endovascular methods, although you see there's significant common femoral artery disease, which in my hands is best treated with a surgical endarterectomy. And then just in terms of the runoff, given that she has wounds, she's going to need inline flow. So then I'm thinking, okay, we're going to do femoral endarterectomy, we're going to do iliac stents, and then depending on the type of conduit that's available, if she has vein, I may do a vein bypass to that above or below knee target, depending on the case. Or I may flip my sheath and go down and do an SFA intervention from the patched femoral artery. So, so in this case, I did a hybrid approach with a left femoral endarterectomy, and I just wanted to show these pictures here. I think we've all seen a femoral artery with a patch on it, but I think this is an interesting, it's kind of a hack for the endovascular portion that if you're having trouble getting your wire up from the femoral artery, I'll often come up and over from the other side and push the wire subintimal, and then just grab it from the femoral endarterectomy site and then flip the wire and be able to treat from retrograde. So we did that in her case. In terms of the technique, I think the main important aspect of doing the femoral endarterectomy and iliac stents is that it's actually almost always an iliofemoral endarterectomy, and the patch needs to go above the inguinal ligament. That way your stents can end inside the patch above the femoral artery. So It's also, actually, it's not just an iliofemoral, it's almost always an ilio to profunda endarterectomy in my patients. And then you definitely want to try to open a stump of the SFA if you're not going to treat the outflow at that time. You want to give yourself a chance to be able to get into that SFA later, or go ahead and just right there treat the SFA or do a bypass. So in this case, I did kissing common iliac stents with extension of the stents into the common femoral artery or iliofemoral endarterectomy, and then proceeded with a fem-pop bypass. And she ended up with excellent waveforms and a 0.95 ABI at the conclusion of that, with healing of her wounds. I didn't have a picture of her healed foot, unfortunately, but you can take my word for that. So the main points of this are that multi-level PAD with critical limb ischemia, when you have femoral artery disease, there's not very many patients who aren't a candidate for a femoral endarterectomy. It's something that can even be done under local anesthetic with sedation. It opens up a lot of options for you. It makes crossing iliac lesions much easier because you don't necessarily have to care about re-entering. I tell the fellows sometimes, just jam the wire down into the femoral artery. You don't necessarily have to care if you're staying in the lumen or subintimal. You just grab the wire and then you can treat it. This disease can be treated in a single setting, including all of the inflow aortoiliac segment. SFA can be treated by flipping your sheath at the end of that and doing angioplasty or stenting, or do a bypass. Thank you.
Okay, we'll move along, and we will have next presentations consecutively. So I will just introduce the two speakers all at once. The first talk will be Dr. Rao on deep vein arterialization, procedural techniques and tips, and will be followed by review of deep vein arterialization by Dr. Arora. Dr. Rao, thank you.
Thank you. Good morning. I'm an interventional cardiologist by training. I'm about 11, 12 years out of training now, and I was in a hospital system for 8 years and tried to set up a multidisciplinary team. After about 5 years of trying, I failed and I gave up. So I said, I'm going to move to the outpatient setting and try to see if I can do it there. So right now we have a neat setup where we have foot and ankle surgeons rotating through our clinic. We see patients together, and we collaborate with some of the surgeons who want to collaborate with us in the community. So we have a quasi-multidisciplinary setup, I guess. So as I moved from the hospital to the OBL, I obviously took a lot of Rutherford 6 patients with me. And sometimes you just can't do anything below the ankle. And in those patients, we know a DVA is probably their best chance. So I'm going to show you my sort of technique for what I have done to make this procedure doable in the OBL, providing a level of care to the patients that's appropriate and also economically feasible. So, I have to say, I was overwhelmed by seeing this in my welcome package. And for Subhash and Mehdi to actually, personally sign this and give it out to every faculty member, I think this is just a very classy gesture. So thank you very much, guys. It's my honor to be here. So pertinent disclosures, I do training courses for Philips. I will be speaking about off-label use of laser and Supera. So it's a 60-year-old male, end-stage renal disease, no diabetes or smoking history, very functional guy, ambulatory, lives at home with his brother. And he had a painful heel ulcer that went on to become gangrenous over 3 months. He was initially seen by us, we did a duplex, found pretty bad disease, and then said, hey, look, this is likely to progress. He kind of vacillated, was lost to follow-up for a little bit, came back when the wound got worse. So he had ABIs, non-compressible, arterial duplex, didn't show any inflow or outflow disease. He had single vessel runoff with a polyphasic AT up to the ankle, and then the DP becomes monophasic. Really didn't have anything other than that. So obviously you went into an angiogram in this guy. So I'm going to talk about how we've used the Pioneer and the Supera to do our DVAs. The first thing we do after the initial diagnostic angiogram, where you show pretty bad disease, is we get lateral plantar vein access. What you'll see here is actually a different patient, and I'll show you pictures of both patients later, but we usually tie a tourniquet once the patient gets onto the table, just venous pressure, and that really engorges the posterior tibial and the lateral plantar veins, makes it really easy for access. In all our DVAs, we haven't taken more than a minute and a half to get into the lateral plantar vein, confirm you're in, and then proceed with your diagnostic angiogram. So from above, so you see the AT coming down, and below the ankle, there's a little movement artifact, but the DP really is nothing. There's no PT to speak of beyond the mid-calf, and then the perineal is a trivial vessel. So the biggest sticking point, so to speak, for me trying to do this procedure in the OBL is obviously the stent grafts are known to fail. John Runbeck's published a paper about the mode of failure of Viabons, which tells you it happens often enough. And then the other thing is, of course, the crossing over. So, August is a good friend of mine, and we've talked about his technique. So I've used the VAST technique in a couple of patients where we put a snare from above, snare from below. I've been doing DVAs for about 8 years now, and I've probably done every iteration: proximal, distal, balloon puncture with a needle, 2 balloons, one in the artery, one in the vein, external puncture with a needle, 1 snare, 1 balloon, all these kinds of things. I even did the Pioneer from above, the one that Bruno Migliara has kind of published about. But what you find is this works great if you have this. You have the vein lie over the artery. You can externally rotate somebody's hip and flex their knee to the point where you might start hurting them, but you don't get this always. More often, if for a distal DVA, which I've begun to do more and more, because the hyperperfusion injury seems to be a little less, you find this. The veins lie on either side of the artery. And then poking a needle through and through from the vein to the artery becomes nearly impossible. So what we do is after we get plantar vein access, we get antegrade groin access, and then do our diagnostic angiogram, and then use a Pioneer to quickly jump into the artery. So we try to go as distal as possible where there's a decently healthy posterior tibial artery. So it usually takes 1 or 2 punctures, and then that wire goes up into the PT. Earlier we used to use snares, but that's unnecessary. What I've realized is you just put a 5 French Bernstein catheter into the ostium of the PT, and that's almost pretty occlusive or nearly occlusive, and you can actually just wire the Bernstein catheter. It's faster, cheaper, works just as effectively. Once you do that, for those of you who do DVAs, the next sticking point is the AV crossover site. It's often difficult to even get balloons across that site, leave alone an 035 catheter. So to expedite the process, what we do now is we take a 1.4 or a 1.7 laser, depending upon if it's a smaller female or bigger veins and things like that. And we actually let that sit at the AV site for barely 8 to 10 seconds. Low fluence, low rate, doesn't have to be really aggressive. And then when you do that, and balloon venoplasty, angioplasty, this is what you end up with, because there's still valves at the ankle and below. So now what we do is we actually, in one swoop, we go ahead and take that laser all the way down and burn those valves. And obviously by this time the sheath from the foot has been pulled out, patent hemostasis. And then you go ahead and balloon venoplasty this and angioplasty this. So once you do that, you still might not get the best flow. And how we have overcome that is not with a stent graft, but with actually a Supera. So the biggest AV steal is usually at the proximal AV crossover site. And by carefully stacking a Supera, you can actually seal the entire thing off. So that's what we do now to try to provide some sort of TIMI-3 flow into the arch, into the pedal venous arch. And this is what the DVA typically looks like. So that's the pre and post. And the most startling thing is you'll see up top where that red circle is, you don't see that initial big fistula going from the AV crossover site, from the A into the V. And this happens pretty consistently if you take your time and slowly deploy that supera and stack it. So this is just one more angiogram. And now what you see, obviously, is that you don't see any calcaneal branches. So this is why there was a young interventionalist that called me from Indiana about a patient with an acute limb, and she said she wanted to do a DVA, and I said, I've been doing this long enough to know that DVAs don't work in cold legs. They're not for acute limb ischemia at all. Yeah. These venules need about 2 to 3 weeks to arterialize. So what we ended up doing was waited to ask the foot and ankle surgeon to actually wait for about 2 to 3 weeks after we did the procedure, and the patient was fortunately stable. And this is what happened when he went to the OR. He bled really nicely. Surgeon was super excited, called me and said, hey man, this looks awesome. I didn't expect this at all. So this does work, even in a foot as bad as this. This was one more foot we did a DVA on. And you can see this is in the OR about 2 to 3 weeks later. There's tons of bleeding. So both these patients did end up healing. Now, who it does not work in is somebody who's already had a transplant. So in my opinion, once you have kind of surgically removed the venules that you want to intentionally arterialize, then there's just no outflow from the pedal venous arch, and it tends to occlude. So I've done about 3 of these now in the last 1 year, a few before that, but they've been lost follow-up. But 2 out of the 3, they're walking. This third one was a retired psychiatrist who kind of forced my hand. I probably shouldn't have done it, but she ended up getting a BK anyway. So, but that's been sort of our experience. We've actually submitted this to JEVT to see if we can try to kind of get this published as a way to do this limb-saving procedure in the OBL. So that's what I've got. Thank you. Any questions?
So what size supera? Because I thought the smallest supera is a 4.5. So are you stacking it, or how? If you have 2 of length, then you're not going to have any radial strength. So how do you do that?
Yeah, so it's not a perfect solution. I think the Vibons are 5. The smallest Vibon is 5, and that's how we all did our off-the-shelf DVA 5, 6 years ago. This is 4.5. So in the veins, it's pretty good. The veins below the ankle are pretty big, 4, 5 sometimes in males who are 5'10" or so. So it's not a problem in the veins. It crushes the valves aside very nicely, so that laser acts like a valvulotome, so to speak. In the arteries, we usually do a good job of dilating them sequentially with 2, 2.5, 3 millimeter balloons. So at the crossover site, I make sure that I pre-dilated the artery well. Is it a perfect solution? I don't think so, but we followed these patients very carefully. So every 2 weeks, we get a flow volume and a peak systolic velocity at the distal edge of the stent. I try not to place it too distally into the lateral plantar. And we look for numbers, flow volumes of 55. I think that the paper basically said flow volume of 55, and then peak systolic velocity of 195. Maybe I'm switching those numbers, but so we usually look for those, make sure that the numbers are not dropping, the waveforms are not getting progressively parvus tortoise. So that's kind of how we follow. I don't think it's a perfect solution, but it's what we can offer for these patients that are offered BK anyway.
The use of the laser is to help establish the communication and then for the valves, both?
Yeah, so technically what happens, I've noticed, is you can't even get an 035 catheter sometimes from the A into the V. And making that laser just sit there just makes that hole much more compliant. And the valves, I mean, those of us, we've taken balloons up to 20 atmospheres and 24 atmospheres, and sometimes those valves just do not yield. You can take a cutting balloon, they do not yield. But you take this laser and burn through those valves. Like I said, it takes under 10 seconds, and every one of them you can inflate with a 1-to-1 balloon at subnominal pressures. The balloon inflates really nicely.
You know, Mehdi, I'd be interested in your opinion, but every person that presents this, they have a different area that becomes problematic for them. You said it takes you 10 seconds to get into the lateral plantar vein. I would say
No, I said under a minute.
It's very challenging to get a wire through the lateral plantar vein, I think, because, and just in my hands, you're probably more, I mean, I've said this to other people, you're probably more talented than I am at getting that, but that vein is so vasoreactive in my experience that it's taken me a while to understand. And right now, I was using the wire that came with the micro kit, but I now use a Command 18 wire. I think it's the best one for doing this, at least in my own experience. And I have to admit, I haven't had as much trouble getting balloons across the crossover point because I've got the wire out the foot and I've got the wire at the groin and I can push almost anything along it. But what I have struggled with is the valves. And I think they're a big issue. And so what I wind up doing is putting like a, you know, if I'm doing an off-the-shelf thing, I wind up putting a 6 French sheath up and using a lamate valvulotome. You can do it through a 4 French sheath, but I'm still using a snare to bring the wire out the foot. I'd be interested in, Mehdi, in what you think is like, what for me the limiting factor is getting venous access. I've had to cancel a couple of cases because I haven't been able to get.
Can I just quickly add to that? So obviously we are very careful about who we put on the table for a DVA. So we kind of label it a pre-DVA scan. So in the outpatient, just like he was referring to, this is sort of an arterial plus venous mapping. So my RVT basically scans the entire path from the common femoral into the lateral plantar vein and mentions sizes. So she'll come and tell me, and there are sometimes when she's come and told me, said, hey, this lateral plantar vein is nothing, and I've not put those patients on the table. But that simple thing of tying a tourniquet, making sure they're euvolemic, if they're not ESRD, you can actually give them a little fluid bolus. Just leaving that tourniquet on for about 10 minutes really works. And I did struggle in the initial phases, getting into the lateral plantar vein. It's not easy. But what I was saying is, through trial and error, we have kind of come up with ways to engorge that vein really nicely.
I like the laser idea for the valve because it's very difficult actually to deal with the 6 French hole in the bottom of the foot at completion of this, you know.
Yeah, so we pull out the sheath before we start lasering. That way you can do manual pressure, because once you arterialize the vein, then you got a 6 French hole you can't really close with manual pressure. And then, of course, once you pass your wire from the pedal venous arch into the AT, you can do a little balloon tamponade also. So,
Dan, real quick question.
Anybody with like hematomas at the bottom of the foot.
I'm just curious, how many in this room actually perform deep vein arterialization? Very few. Okay.
Dan, real quick question, if you don't mind. You have a lot of, Dan, Claire, you have a lot of experience with DVA. As it may go to the outpatient world and people are doing more and more things off the shelf and looking at cost containment, are there any things that you just can't compromise on this part of the procedure? In other words, the valvulotome, for example. Is there something that if it swings to the OBL, again, no disrespect to the speaker whatsoever, I'm just in general, is there anything that you just can't compromise on this part of your DVA or you're going to have bad results?
My own impression is the biggest issue is getting the valves in the bottom of the foot. And it's not real, I guess I shouldn't just say the bottom of the foot, because there's often a scarred or heavily intensified resistance to dilation in an area around, because most of these are done through the posterior tibial vein, the area behind the medial malleolus. You have to make sure that that area is opened up adequately or freed up adequately that you can dilate it. I try to pass the valvulotome 3 or 4 times through that segment, and I think if you don't do that and you don't resolve the valve issues in the foot, which again, I like the laser actually, I think offers a good option to do that, because if you don't have access far enough out in the foot, you can't use the pull valvulotome in those valves, and then you've got a problem. And just dilating with a balloon oftentimes just damages the vein. It doesn't really do anything to the valve itself.
Yeah, the only thing I would say is that, these are very select patients, because most of the patients that we enrolled in this study, we talked about this last night, had severe tibial disease. So these are patients that have very nice, posterior tibial all the way to the ankle, and they have to be amenable to a 4-5 supera, like you said, right? So these are really juicy, in addition to the valve issues that you discussed, which is consistent regardless of whether you're doing proximal or distal DVA or surgical DVA, is that, you have to have it, and I think it's good to have this tool, another technique in our armamentarium. If you have a patient that somehow has, reasonable and nice juicy arteries to the ankle, but then gets to be a desert foot, that you can maybe utilize this because it does help with the proximal steel. So to your point, one of our challenges with this procedure is proximal steel. When we do it from a proximal DVA, and we knock out those collaterals and branches to the foot, because it takes time for maturation. So if you're doing it, the more distal you're doing it, hopefully you're preserving more collaterals. So there is something in this procedure. I just think that hopefully we get the right tools, but you really need to have a very nice PT way by the ankle to be able to create this.
Do you think the covered stent is necessary? I mean, I think this is interesting, and that's a question to me is a covered stent just at the AV site, or does it help you kind of with some of those initial valves? Maybe, like you said, proximal over distal. I'm curious what you guys think.
So I've done a couple without covered stents, and I think he's right. You can occlude it. I don't know the long term of that. I think what happens is you put those branches into spasm initially. I'd be interested because the patient I did 2 of these on, actually ultimately the family went on to put him in hospice care just because of multiple other issues that were going on. But I think at the end of the day, you're probably going to find that you don't need covered stents through the whole darn thing.
Okay, I think we should move on to next. Dr. Arora.
Hello. Okay. I'll be presenting a deep vein arterialization case. It's going to be a lot of similar steps as Dr. Rao mentioned before. My name is Shilpkumar. I'm endovascular fellow at University Hospital, Harrington Heart and Vascular Institute with Dr. Shishehbor. In fact, this is the case we did with Dr. Shishehbor. I don't have any disclosures. So we have this 55-year-old young gentleman who has very aggressive Berger's disease. He already underwent left BK a year before. Was still using a little bit of tobacco about 6 months ago. Was referred to us for right second and third toe ulcer and possible amputation. There was on physical exam, there's no palpable pulses, pedal pulses, and the foot was cold to touch, but no motor or sensory deficit yet. Just routine medicines. He was on cilostazol, clopidogrel, and rosuvastatin and baby aspirin. And this is how the foot look. As you can see, it doesn't look good. We did. I don't have the ABI just because it's done outside, but it's pretty much flat line on the right side. We did take patient to the cath lab. We did the angiogram and shows the inflow in terms of iliacs and femorals are not bad. They have mild disease, but nothing occlusive. On the right side, the profunda and SFAs are pretty much streamlined. At knee and below knee, where the problem starts, we have Albert disease in popliteal, but below knee, even though that's not a great angiogram, you have to take my words, that AT starts but never finishes, and TP trunk doesn't divide into PT and peroneal. And this is how the foot looks. It's quite deserted. So how should we approach this is a question for me when I start this fellowship, I guess. Do you guys think there's any endovascular or surgical approach for those angiograms you see, or would anybody go for amputation? Any hands for amputation? All right. So yeah, we decided not to go for amputation. We give it a try with endovascular methods to open up AT and PT both, but apparently not successful. So eventually we do what we do. We discuss this in Limb Salvage Advisory Committee, and then mutual decision between surgeons, vascular medicine doctors, vascular interventional cardiology, and podiatry was made to try a deep vein arterialization using a percutaneous route. But we tried to enroll this patient in trial, and trial committee denied because of the Burgess disease. And I think history of smoking 6 months ago, there was some cutoff there. But as Dr. Shishehbor says, we always do right things, not wrong things. So we go ahead and did it anyways, off shelf. All right. So, as Dr. Rao mentioned, we get an arterial access, lateral plantar, did a venogram, and then venous access, did the venogram, and then take an arterial access from north. Align both venous and arterial catheter using the ultrasound outback. This is just a little bit of animated presentation, how we do it. We align it with the ultrasound outback, then cross from arterial side to the venous side using a 014 wire. This is something how it looks, and a facilitated re-entry. We then go ahead and put the covered stent, Y-bend stent, from artery to the vein, and then followed by destroying valve using the valvulotome, and did an aggressive angioplasty to make sure there's no residual narrowing in the veins. This is the follow-up angiogram. So as we can see, inflow is pretty good. The vein looking okay here. In the foot, can you play the first picture, please? In the foot, so we see a bunch of shunting going backwards, and the arch was not complete. So we complete the procedure by doing a little bit of venoplasty and occlude that shunting that is going backwards using some coils. We got a pretty good results. And this is after a few days. This gentleman underwent a transmetatarsal amputation, and with the secondary healing, we got really good results. He's currently walking. We saw him a couple of weeks ago, and is doing well. Just few pointers that we learned during this duration of the trial, that Rutherford 5 or 6 with no surgical or endovascular options are the only patients that we should go ahead and do this procedure. The ischemic rest pain in case-by-case basis, sometimes we consider if there's literally no other options. The things that we should really be careful before and after the procedure is the extensive tissue loss. Patients should have, must have an intact deep venous arch, and infection should be treated very, very aggressively with podiatries or surgical colleagues and antibiotics. Immediate post-procedures are not fun. They have a lot of pain for a few days to a couple of weeks. The bluish discoloration becomes apparent in a few days after the procedure, or immediately after the procedure till few days. And the swelling and pain slowly goes away as the transcutaneous oxygen pressure improves. If we have suboptimal outcomes, it's usually because of one of the two things, because the possibility there's a lot of outflow shunting, or there's inflow stenosis, and they both are addressable. The inflow stenosis usually can be fixed with angioplasty or all the tools that we discussed in the last 2 days. And then outflow shunting can be managed by basically, occluding those vessels with all the techniques we have in terms of coils and fat embolizations and whatnot. And then wound healing after the procedure is very, very, very important. And it takes longer, you have to tell the patients up front, it takes longer than the direct arterial revascularization. And usually it takes a secondary healing than a primary healing where you let the wound open because the swelling otherwise make things and necrosis really, really worse. The patients should be on a DAPT with oral anticoagulation until usually the wound heals. We try to do Xarelto 2-5 and Plavix until the wound heals. The patency of DVA is utmost requirement for the healing. If the flow is less than 100 ml, the chances you're going to have occlusion of that graft and unsuccessful wound healing is really high. So sort of close monitoring of these patients and duplexes are important. And finally, as we discussed all over morning, dedicated multidisciplinary team is key to success on any of these procedures, including DVA. Just a quick slide on a trial. I know we're not presenting data too much, and this Dr. Shishehbor already mentioned this. In PROMISE-2 trial, we had 99% success rate in terms of procedure success. We have limb salvage rate of 76%, and amputation-free survival at 6 months was 66%. Non-hemodialysis patients had amputation-free survival of 75. As Dr. Shishehbor mentioned before, dialysis patients don't necessarily do as well. They're really, really sick. Now PROMISE-3 trial is going, and we're enrolling patients at this point of time. Thank you, and I'll take any questions.
It's a great job, a great presentation. You know, it's so interesting to think about a future for this and some of these microvascular pathologies, because folks with progressive microvascular, terrible conditions where they're just progressively losing digits were obviously excluded from these trials. But do you think there's a potential future for DVA in some of these patients that we try to treat with prostaglandin infusions and they're painful and they don't work somewhere on the horizon?
I would like to hope so. Again, you know, this is the field we're just starting in the territory, and where I am, I think we're making a great progress, and we would like to treat some people and see if it works. And if it works, we probably would do studies and trials to answer your question, hopefully in the near future.
Interesting, you know, we've done that. I don't know what's your experience, but and Matt and whoever else is doing DVA, but you know, so far I've had 2 patients with vasculitis that have been excluded from the trial. So one of them had Church-Strauss. I think you know that patient. And that one we did as compassionate, and she healed, and she's still doing fantastic, 6, 7 years old. And then this patient, which was Berger's, which is the only Berger patient that I've done, honestly, DVA on, and both of them have done well. So I don't know, even though we are excluding them, somehow, at least this is an anecdote, you know, but 2 patients, but I don't know if you have done any patients like this.
You know, I think we're going to find, and I've said this before, I think we're going to find other uses for this as well. I actually did this, did venous arterialization in a patient who had had acute limb ischemia and had been lysed, and we were unable to completely open up the forefoot. You know, he still had severe pain. He was starting to lose the dorsum of his foot, but it wasn't somebody that you'd look at and say, okay, he needs to have an amputation. And I wound up doing a venous arterialization. And what was interesting about this guy was his foot got better very rapidly. And I think it's a function of there's a different pattern of the way this works in people with differing diseases. We're doing it right now in people who have horrendous distal arterial disease. I'll be really interested to see when this is used in other settings, like people, you know, the interesting thing about that case that you just showed was that wasn't a typical, like, loss of the distribution system in the foot. It was, those arteries were not as diseased as we're seeing in the patients we're enrolling in this trial, and I think it performs differently in those patients.
Dan, real quick question. I know we're pressed for time, and Mehdi, but first, let's say you mentioned all the wound post-DVA, you know, the swelling, the pain, and so on. What if somebody sends, Kingsport, Tennessee, I send you across the state a patient. When they get done at that place and then they go home to a place that doesn't do DVA, do you train them on what the post-op care is? Because otherwise, we could send them for that, but then some surgeon who doesn't recognize this takes their leg off because they don't. What do you do in the post-follow-up if for somebody who's a referral?
Yeah, that's a great question, because I have patients who are from out of state that are seeing us now for this. And basically what I'm doing is I'm communicating very aggressively with their wound care center, because, and I'm also making sure that I'm managing their pain because you have to, they don't get pain relief at the same rate as somebody who has an arterial revascularization. It takes about 6 or 8 weeks before they start to feel the benefit in terms of healing that's going to start initiating. So, you know, if you're going to do this and you're going to send them back to a surgeon who's skeptical, because I've had that happen too, where a patient, I did the procedure and 3 weeks later the patient was in an emergency room and wound up with an amputation. So I've also told the patients before they go to an emergency room, before they do, you know, have consent, that they have my cell phone number, so they can call me, and they occasionally will.
Dan, let me ask you a quick question. You know, when the surgical deep vein arterialization was initially described 30, 40 years ago, it was actually done at the level of just above the malleolus. Nowadays, this percutaneous is done usually at the level of the tibioperoneal trunk or below the knee pop. Do you think there's any role for surgical at the level of the ankle? And if there is, when would you do that as opposed to?
Oh, yes, so there's no question that there's a role for surgical DVA. I mean, if you're going to offer this to people, you have to be offering it like arterial interventions, surgically and interventionally. There's still a large group of patients, so people who have SFA occlusions or popliteal occlusions, we don't have a good percutaneous option for them. They can have their saphenous vein used as an inflow source for venous arterialization, or they can have a bypass graft to the ankle and actually just take a dilator, a Garrett dilator, and pass it through the veins of the foot to do this same procedure and rupture the valves in the foot. But yeah, there's no question that there's a role for surgical issues related to this, performance of this procedure as well.
Great, thank you very much for interesting.
Thank you.
Discussion. In the interest of time, I think we should move along. And the last talk of the session will be Dr. Hammad.
Thank you. Okay, so I'll be talking about limb salvage board and the future of multidisciplinary team. Okay, so I'll start with a case. It's a 79-year-old lady, severe left leg rest pain and left second toe gangrene. Her most recent presentation where we did this procedure was in February 2022. She has a lot of multiple intervention in 2021 and shows the next slide mainly for left leg rest pain. She's active smoker, frail, CAD with RCA, PCI in the past. This is a list of her intervention 2021 from January to November. She has been a mutual patient between interventional cardiovascular surgery. As you can see in January, she had rest pain and she underwent PTA-DCB to the SFN popliteal. She also had below the knee amputation with bioabsorbable stent for outflow because she didn't have an outflow. In June, she came back with rest pain. At that time, we referred her for CFA endarterectomy. She underwent one back. She came back a month later, still rest pain, and now she had tiny second digit toe gangrene, which actually, underwent for stenting of the SFA and popliteal and again PTA to the PT. And 4 or 5 months later, her tiny wound in the digit had healed, but she came back again with rest pain, and this actually was where my involvement with her started. At that time, I felt for rest pain, let me just balloon the profunda. You'll see in the next image that she has actually 2 profunda. One of them is large, but very tertiary disease. And I just ballooned the smaller one, and I think she still had continued to have chest pain. Didn't really work well. Okay, so that's her presentation again in February 2022. And this was inpatient service. We don't do a good job at taking pictures in inpatient service. I don't have a picture of her left second toe gangrene, but her x-ray showed osteomyelitis with left second distal phalanx. And those are ABI waveform on the left, as you can see, very damped, at the ankle level and flat at the toe level on the left side. And those some of her diagnostic angiogram. Again, as you can see, she has occluded the SFA, and she has 2 profunda. The one to the left, that's the one medial I ballooned in the past, and the one lateral, that's the one provide most of the collateral, and that's one very tertiary, was very calcified, very diseased. And she has some reconstitution at the PT level, and she has nice plantar into the foot. Okay, so patient was considered for left fem PT bypass, and vein mapping studies were obtained. However, due to the veins were not optimal for the grafting and her age and frailty, she was deemed not a best candidate. So how to manage this patient? She has persistent left lower extremity rest pain. Actually, she was labeled with neuropathy, which was not true. It was her own ischemic rest pain. And now she has gangrene, and she had failed multiple revised attempts, and she's not a great surgical candidate.
How would you guys approach this? Because that's why we have LSAC, okay, Limb Salvage Advisory Council. So, you know, the LSAC members met, and the beauty of this LSAC, not just multidisciplinary and multiple specialties, especially at UH, and Dr. Clair emphasized this point that we have multiple providers within the same specialty, because obviously I don't have the skills that Dr. Shirlling has. So if I can't get it done, and maybe he can get it done. And same for the surgical colleagues. So we have actually in all of these meetings, we have at least 4 or 5 surgeons, we have at least 3 or 4 interventional cardiologists, and we discuss these cases. So we discuss the cases, again, reviewed the vein mapping, everything, and the story, and we felt, you know, still not a bypass candidate and maybe another revasc attempt. She was, she stayed over the weekend and I was there Monday cath lab, so I actually had the chance to do her procedure, went up and over, you know, just again, some of the images. We crossed through the SFA stent, took more angiogram, same reconstructed at the PT level, and we had to come, we couldn't cross past the populate into the TPT, so we had to come retrograde, rendezvous, externalize, flood the wire, do PT, ADCP. I did laser at this time as well. And again, same balloon angioplasty for the TPT, and those were her final angiogram. During same hospitalization later in the course, about 1 week later, she underwent a left second toe amputation. Okay, those are pre and post. 6 months later, second toe gangrene healed, amputation site. And this 12 months later, she's part of the study because she got in the past live PTK trial bioobservable stent, so she still get duplex ultrasound for this. And 12 months later, her ABI looks good, TBI looks okay, and the stents in the SFA and the live PTK bioobservable below the knee is still patent. So just this background, that to remind everybody that CLI is extremely undertreated, even in the high-intensity regions, where you have supposed to have good care and multiple specialties. 40% of these people don't undergo any vascular procedure in the year prior to amputation, and in other areas with a low intensity, actually, is even worse. Almost 2/3 of these patients don't even get an angiogram or any type of a revasc attempt in the year prior to amputation. And this is just to show the significant disparities in outcomes like amputation across the United States. So the old model, at how we had it at the Harrington HVI in the University Health in Cleveland, that provider like me maybe sees a patient, attempt revasc, may not run by a colleague. If I cannot do it, maybe I'm not saying I would do this, but I'm just saying most of these were done in silo decision. That maybe it's up to the provider if they're going to refer to another colleague from same specialty, different specialty for better outcomes. So a lot of silo decisions that patients sometimes end up with amputation, even sometimes the podiatrist or the vascular medicine colleagues, feel this non-salvageable. So we implanted this, LSAC, Limb Salvage Advisory Council in place, and nowadays everybody who's planned for amputation before they proceed their amputation, we have to meet and discuss as a group, and again, it's just not multiple specialties, but multiple providers with different skills and expertise within each specialty. And then at that point, we either decide that, yes, patient, the foot or the leg is non-salvageable, proceed amputation, or no, this is worth another revasc attempt, whether surgical or endo. So it's a process. Jenny is here. Thank you, Jenny. So once we identify a patient, she gets called, she arranges for a meeting, fellow present, we meet and make an action plan. This is just our experience at UH in 2019. We published this in Circ. Basically, we had, in 2019, we had 19 patients that were referred to LSAC. 3 of them were deemed as non-salvageable and underwent amputation. Out of the 16 left, 1 had unsuccessful attempt, but 15 had successful attempts, so 95% successful revasc. And out of these, 75% had their limb saved at 6 months. So key points that CLTI is extremely undertreated, remarkable heterogeneity of care, and significant disparities in outcomes, especially amputation. I think, with our experience and everybody's emphasizing multidisciplinary approach, that I think it should be a point where health system and policymakers need to mandate that every patient with CLI that is scheduled for major amputation needs to have some sort of formal interdisciplinary approach like LSAC prior to proceed with amputation. Thank you so much.
So I apologize, we've sort of gone way over. We'll wind up ending up this session in 15 minutes to visit the exhibitors before we start our next session. Thank you very much to all our speakers and to the audience.